So hi everyone, welcome to our next webinar session for Careers in Paediatrics. I'm Charlotte, I'm the UKAPS president at the moment, and this is the Tony Jackson Prize session. So can we have the next slide, please? So UKAPS, as hopefully a lot of you know, is the National Society for Medical Students and Foundation Doctors who are aspiring to be paediatricians. We work very closely with the RCPCH and foundation doctors and medical student paediatric societies around the country. You can find us on Facebook, Twitter or Instagram, and please give us a follow because we post a lot, especially on Twitter, and we retweet a lot of stuff. The aim of our society and why we were set up was to help support medical students and foundation doctors finding their footing in the world of paediatrics. Next slide. So we have a lot of events just to make some of you aware of before we get started. So we've got Foundation Doctor Career Events, a yearly conference which has been delayed this year, obviously due to the COVID pandemic. But we're hoping to deliver it some way next year. We support local paediatric society events. We've got these webinars that we've started doing, the Tony Jackson Prize. We send out a monthly newsletter as well, and we do have a session at the RCPCH conference as well. Next slide. So how you can be involved with us. So we've just released today some new committee positions that are available. So we're growing our team every year. We have a lot of foundation doctor representatives positions available around the country, as well as some more in-house ones, such as vice president roles and webmaster roles. So please do have a look on our Facebook, Twitter and Instagram, and you can find the link for the applications there. You can also be involved in emailing us if you have any interesting articles or you've done an interesting event in your student society or foundation doctor locally that you think other people should know about, then please do send us an email or a Facebook message or Twitter message, however you message best, and come to our events like you're all doing now. So we'll get started with the first speaker for the Tony Jackson Prize.
Hi, so good afternoon to all. My name is Amandine Duray. I'm an F2 from Northwest London. Thank you so much for having me, first of all. Today I want to share with you some stories and lessons I learned during my elective in Tokyo. I had the chance to follow the Aozora Sumida clinics, which are home visits for children with palliative care needs. These were created by a general pediatrician, Dr. Maeda, who noticed that in Japan, there were more and more children with long-term disabilities and palliative care needs, and that these needs were often too complex to assess in a hospital, a traditional clinic, and he felt that these children could be much better cared for in their own homes. So on this picture, you can see very modern Tokyo with the Tokyo Tower towering over landscapes, skyscrapers. But if we can have the next slide. When I was in the back of the car with the pediatrician and the palliative care nurse driving from house to homes, reality was a little bit different to the very modern state-of-the-art hospitals I'd been in so far in those big skyscrapers. And already I was seeing quite a difference to the kind of medicine I'd been experiencing so far when I ventured a bit more into the residential Tokyo. So it was me and then the team, which was the doctor and the palliative care nurse. And together we were going and knocking on people's doors who had children with life-limiting conditions. If we can have the next slide, please. So Tokyo is a very densely populated city and space is often very scarce. I remember being very surprised when I walked into the first home by how much of the living space of people's homes was being taken up by ventilators and other bulky medical equipment. And to me, that really brought home something that you don't always see when you're just seeing a patient in hospital or in clinic, which is how much physical space, but also how much head space having a child with a long-term disability can take up. The dynamics of the visits were so different to what you might experience in hospital, because here we were clearly guests into someone's life and someone's home. So we would respectfully take off our shoes at the entrance and greet our hosts. And then we would sit down on the tatami floors with our baby patient between us, playing happily. And it felt like parents and children both were so relaxed and just so open, especially in Japan, where public and private lives are very demarcated, and that you can feel some reserve sometimes from your patients and their relatives in clinic. But here, everyone was so relaxed, and it felt we had all the time in the world to explore what life for this child was like and how we could make it better and how we could help. And also sometimes you'd see sort of healthy siblings running around, and then that also reminds you how, however complex and difficult it might be caring for a child with a long-term disability, sometimes there's even more to that than that to the picture, and there's other siblings as well to look after. It really felt like something was unlocked in the relationship between doctors and relatives when we were in their homes. So instead of it being the traditional healthcare professional to patient or relative, sort of the healthcare professional giving advice, here it felt much more like it was two people who were experts at looking after a child with certain conditions and symptoms, who were exchanging ideas and experience and collaborating really to improve the life quality of the child. If we can get the next slide. I also felt that compared to what I'd experienced so far in the UK in paediatrics, there was very little that was off limit for the doctors and the nurses to advise about. So we might, guide patients and their relatives about what kind of doses of certain medications they should be taking and such. But also we would answer concerns and queries from parents about things like feeding or chest physiotherapy, which is demonstrated in this picture. Or even Dr. Toyoma, who was one of the pediatricians I worked with, would show parents how to do certain massages to relieve their baby's painful spasms. And it really felt like truly holistic medicine that was very tailored to the patient's needs. I witnessed some first visits for patients that were new to the clinic, and the relief that I saw in the face of the parents was really quite something, because again, when you're in a clinic and you see 15, 20 children that have similar conditions or similar needs, you may forget how isolating it can feel to be the parent of a child with a long-term disability or rare condition, and having someone come into your home with that expertise and that knowledge to be able to ask your questions to and guide you is really something invaluable. We can switch to the next slide, please. So this slide sort of demonstrates how perhaps initially I was drawn to the clinics for the wrong reason in a way, but what I learned sort of went beyond what I expected to learn. So what first attracted me to the Aozora Sumida clinics is that my scientific and clinical interest lies with rare inherited diseases and genomic medicine. And I felt that that would be a great chance to meet children with rare inherited conditions, to see what kind of care they needed, and to, practice my freshly acquired developmental assessment skills from my pediatric OSCEs. But actually, what I learned went so far beyond what kind of chromosomal deletion that baby had or what kind of mitochondrial disorder that baby had. And to be honest, now, you know, it's been some months and I wouldn't be able to tell you exactly what was what. But what I do remember is just so many individual children that were being looked after as people and not as conditions, and the warmth that they were being looked after with, and just how everyone was working together to make sure those babies and toddlers had lives that were as fulfilling and as symptom-free as possible. And I think the clinic being in people's homes definitely played a big part in that. If we can have the final slides, please. So the final slide is just to consolidate what I've been talking about and sort of reflect on what aspects one can bring back to practice in the UK. I think what really struck me, as I said, was how the medicine that was practiced in those clinics was really personalized in that we were taking each child as an individual case with their very specific life circumstances, and seeing how we could tailor our management plan to these life circumstances. In the UK, the privilege of going into people's homes is often held by occupational therapists or other allied health professionals or GPs, but rarely by paediatricians. And I think, during COVID, it would even be somewhat of a sort of dangerous idea to go around and visit lots of vulnerable children. But I think there is still something we can take from this that we can apply even from the wards or from the hospital, which is just that it's not often that we get to see how our patients live. And we can think about, this child that I'm seeing today in A&E or on the ward or in clinic, I wonder what kind of home they're going back to and what kind of life they're living. Do they have siblings? What kind of a place are they in? What's life like for them? And I think having that approach will really help you communicating with the families, having realistic management plans that will be successful and progress the care of the child. And I think even if it's not quite implementing the Azora clinics, it's still a step in that direction. So thank you for listening. I'm just going to see if we have any questions from anyone. It's okay if not, but otherwise it's been really nice talking to you, and I'm looking forward to the other presentations.
Thank you so much for that, Amadine. That was really thought-provoking, especially seeing it and hearing about it in not our country as well, and hearing it from a different point of view and how culturally wise things are different as well.
Thank you.
If there's no questions from anyone else, you can use the question and answer thing if anyone does. We'll move on to our next speaker. So this is Ella from St George's University. So I'll hand it over to her.
Hi, good evening everyone. It's really nice to be here, and thank you so much, Amadine. There's a lot I'm going to take away and think some more about from your presentation, so thank you. My name's Ella and I've just started my final year at St George's, and I'm going to be talking today about the climate emergency and the implications of the climate emergency on child health. It's something I'd never really thought about before my paediatrics placement last year, and it's something I've been reflecting on ever since, because I think that although we all probably know intellectually that the climate emergency is real and has real health implications, it's very easy to feel like it's not actually that relevant to our day-to-day working lives. So if we could go to the next slide. This reflection was prompted by a child I clerked in a South London A&E. I've disguised some details here, but let's call him Sam. And I met Sam just over a year ago now. It was the hottest July day that had ever been recorded in the UK, and Sam had come in with an exacerbation of his asthma. And as I talked to him and his mum explained that they were from the countryside and they were here to visit her parents. And she told me that that wasn't something they did very often anymore, because every time Sam came up to visit his nan and go for a chalk ice in the park, they ended up in A&E with nebulized salbutamol and the little pink steroid pills that made him vomit. And when I got home that night, I did some Googling and I started to realise that there was a wider context to what I'd seen on placement that day. Sam may be just one child, and this is just one anecdote, but there is mounting evidence that deteriorating air quality accounts for as many as 1 in 10 childhood asthma admissions in London. I think this was the first time that I'd realised that the health implications of the climate emergency, and in particular for children, aren't a problem of the future or of other places, but part of the fabric of paediatric practice in the here and now. But before that paediatrics placement, I'd never given much thought to the effects of climate change on health. I kind of vaguely knew that global warming was something I ought to be concerned about, but it didn't register with me as something that was particularly relevant to my medical training or even to the lives of the patients that I was seeing. And when I met Sam and I did begin to think about this issue, the scale of the threat just seemed overwhelming compared to my ability to confront it. But over the course of the year since I saw Sam in A&E, some new and really powerful voices have emerged to model how to do just that, to show us how to confront this overwhelming issue. And those voices are the voices of children, children on school strike, children holding their leaders accountable for their inaction and apathy. And they're children from whose example their doctors might learn how to tackle the climate emergency with verve and energy and concerted effort. If we go to the next slide, we'll see some of those children. And I'm sure that images like this have become familiar to many of us over the past year or so. Images of children taking upon themselves the responsibility for concern about our environment. And they're right to be concerned because the climate emergency affects children and the health of children in unique and specific ways. It's obviously the children of today and tomorrow who, as they grow up, will disproportionately bear the growing burden of climate change. But the World Health Organization estimates that children under 5 already suffer over 88% of disease caused by climate change. I think at this point it's easy just to switch off. And that's why it's so important that when we meet a child like Sam, we put them into this context, because it's often so much easier to grapple with the changes we need to make to protect individual patients rather than taking on responsibility for the health of the whole paediatric population worldwide. But protecting the health of a child like Sam does mean taking action. That's been my key take-home message on what has been a real reflective journey for me since I first met him. The thing that I don't know whether medical school has tried to teach me, that it's not always enough to manage your patients well and then go home and sit back while the underlying determinants of ill health continue to grow. But at this point, it becomes a kind of a reversal of a question that's maybe more often asked in paediatrics and paediatric bioethics. It's not just because we can, should we, but just because we should, can we? And if we could go to the next slide, please. I'm going to argue that the answer actually is yes. And The actions we can take potentially range from the small to the large, but they all make a difference. This is where thinking about small changes to the way you manage individual patients comes in, because it's something we can all do, and it is potentially really powerful. There are so many achievable changes that we could make to the clinical environment, from reusable sharp spins to reducing the use of non-sterile gloves to changing prescribing practices. A child like Sam is likely to be discharged with an inhaler and a weaning schedule, but prescription of metered dose inhalers represents 4% of the NHS's total greenhouse gas emissions, and metered dose inhalers represent 70% of all inhaler prescriptions in the UK, compared to a country like Sweden, where they represent only 10%. Now, obviously, clinical considerations have to be absolutely foremost when making prescribing decisions, and there's an obvious place for metered dose inhalers in paediatric practice and with younger children in particular. But if we go to the next slide, we can see that even within that, we could make changes. So the next slide shows that generic salbutamol inhalers generate around 10 kilos of carbon dioxide per inhaler, compared to 28 kilos for the branded Ventolin, because Ventolin contains a particularly large amount of the propellant gas that makes inhalers so bad for the environment. Now, I did a calculation on the US Environmental Protection Agency's online carbon calculator, which I recommend you all go and play with. And that told me that 18 kilo saving is enough to charge a smartphone over 2,000 times. And something else we could all do is just educating patients about how to dispose of their inhalers. I'm asthmatic, and before I researched this presentation, I had no idea that inhalers could be recycled and that propellant gas can be reused. If you find out where inhaler recycling happens near you, there's a nationwide scheme run from thousands of pharmacies, then you can make sure your patients know about it. But these individual choices only take us so far. Doctors retain a perhaps increasingly unusual place as people with a position of authority that remain generally very well trusted by the general population. And paediatricians are the doctors with the most unambiguous moral and professional responsibility to safeguard the health of children. So if we go to the next slide, these are my key learning points: to recognise that responsibility, to consider what changes could be made to day-to-day clinical practice, but also to acknowledge what a privileged role healthcare professionals have in advocating for the systemic changes needed to protect child health, both now and in the future. This is what meeting Sam taught me. So if we go to the final slide, it seems appropriate here to give the final word to a child. This is Greta Thunberg's speech to Davos last September. She said, "You have stolen my dreams and my childhood with your empty words. The eyes of all future generations are upon you. And if you choose to fail us, I say, we will never forgive you." Thank you very much. So I don't know if there's any questions, but if not, I'm really looking forward to hearing Kelvin's presentation.
Thanks, Ella. That was really good from you. So you mentioned that you've done take-home messages such as your asthma inhalers, but with the child that you mentioned and him obviously coming to London and obviously the air pollution levels, what would your take-home message be for children who live in inner cities with high air pollution levels, which obviously during COVID have lessened, but have not lessened enough necessarily for them to be unaffected by them? How would you approach that in your clinical practice?
So I think that this is where my kind of final point about advocating for systemic change comes in, because I don't know enough about paediatric respiratory health to know what kind of changes can be made to the life of any individual child that will make that kind of difference. And what will clearly make the difference is, as you said, the kind of changes we saw during COVID with reductions in car traffic and that kind of thing that make a huge difference. One change I've made on a very personal level, which isn't part of my clinical practice, but I have a wood burning stove in my flat. It was this thing that we were so excited about. We came to see the flat. We were like, this is incredible. And since meeting Sam and learning more and more about this, I've completely stopped using that, and also trying to persuade everyone else I know with want to stop using it because of the particulate emissions from wood burning stoves, which are really deleterious for paediatric respiratory health.
Great. So there's a lot of, moving on from Ella, if anyone wants any more information about it, there's obviously a lot of articles online, and it's a really big thing at the moment, air pollution. And there's been multiple systematic reviews and overviews of systematic reviews looking at air pollution in respiratory health in children, if people are keen on that. So now we'll move on to our last speaker, which is Kelvin. So I'll hand over the reins to him.
So my reflection is about something that I find challenging in paediatrics and various ways that I've got to come to terms with that. So my first peds block, I did that in the run up to Christmas last year, which, as I'm sure you can imagine, was the most heartwarming 4 weeks, right? So I spent 4 weeks doing Christmas carols and wrapping presents and talking to kids about what Santa was going to bring them for Christmas, and it was great. Next slide, please. But I met this one baby who spent their whole time that I was there kind of sleeping by herself in this little dark room off the ward, usually on her own. And throughout my placement, I spent quite a lot of time learning about her medical care and talking to her parents who came in every day and brought her clothes and hung like a banner on the crib with her name on it. And I also met her social worker because she was being treated for substance withdrawal. She was a neonate. And her social worker was in every day because her parents weren't allowed any unsupervised contact. As medics and paediatricians, our aim is to optimize child health. But for a baby like baby P, the baby I met on the ward, it isn't immediately clear what that means for her. We might be able to look after her physical health while she's in hospital, but there are these other aspects like mental and social well-being. Growing up in adversity has lifelong impacts. Kids who experience disruption of care in early childhood, or whose parents and caregivers have substance abuse problems or mental health illness, kids who live in poverty or who are in and out of foster care, all of these experiences are likely to lead to poorer mental, emotional, educational, and social outcomes than kids who grow up in more stable environments. This is a reality. This isn't controversial. This is a reality that I've struggled with for a really long time. But there was something about meeting this tiny little withdrawing baby on the ward and having this contrast of all these other temporary sick but generally happy bouncing kids who were talking about their Christmas presents. And that contrast really brought it home to me. Some people are born into environments that confer every possible advantage, and others are born into environments that just don't. Next slide, please. So I know that statistics, although they are true, they confer probabilities rather than destinies. So the statistics are limited in what they can tell us about individual life courses. So while baby P might have poorer odds than the kid in the ward next door, she's not inevitably bound by those odds. However, I don't find that particularly helpful. Next slide, please. Like baby P, like lots of kids, the odds when I was growing up were not in my favor. And yet here I am in my mid to late 20s, and I'm pretty happy and successful, and I'm socially and financially quite stable. So statistically, I'm this one person who's made a success of it. But one of the hardest byproducts of that experience is that in the 10 years since I left home to go to university, I've been able to watch this gap emerging between the quality of my life and the quality of life of my former friendship group and peer group. And this is a gap that's evident financially, but also in the quality of our relationships and in the health that we enjoy and the health choices that we make, and also in the general wealth and depth of experience that we can get out of our lives. Next slide, please. So although this individual baby P, may or may not be one of the kids who, makes it, the fact remains that the bulk of children like baby P are going to become disadvantaged adults who then themselves go on to have disadvantaged children, because trauma and adversity like poverty and substance abuse, they do tend to be transgenerational. Next slide, please. So this is profoundly depressing for me, both personally and professionally, and it's a problem that doesn't have like an obvious, easy fix. So some of the things that need to be done are obvious, like children's services should be well funded and kids should have equality of access to education. But these solutions are big national and political things that are hugely challenging, and I really needed to find a way to deal with how much this bothered me in the meantime. How do you work in pediatrics every day or work with children generally and not find the unfairness of this impossible to tolerate? Next slide, please. So I think one of the answers that I found was remembering that the life that is perfect for me isn't necessarily the perfect life, right? So medics and doctors, I think, are particularly prone to that kind of fallacy because we work so hard to get into medicine, and many of us believe, at least some of the time, that we have the best job in the world, which is actually what Emma said at the beginning of this meeting, which worked really well for my presentation, right? So for me, there are really good things about being a doctor, and then there are also really great things about being a doctor, right? It's exactly the kind of job that is suited to the kind of person that I am, and I really feel the privileges that I get to be part of this profession. But I know, because people have told me, that this isn't true for everybody. I know that there are people who have the option of being doctors, but who choose not to because it's not for them. Next slide, please. So I find it really tough looking at the pathways that my old friends or peers have taken, and then seeing the differences between those and the paths I have taken. But the fact that I respond to their lives with pity or compassion, that involves me making a judgment that what they have is not as good as what I have, right? Now, there are some material ways in which that is genuinely true, but most of the differences between my life and their lives comes down to me being prejudiced. So I think one good example that highlights this is the example of if and when to have children. I'm in the minority of my peer group from school in that I don't have children yet. And I hope to have children, I expect to have children, but I want to do it intentionally when I'm able to give them a childhood that doesn't have the same hardships in it that I experienced when I was growing up. Most of my peers had children kind of less intentionally, and then they figured out how to deal with it as they were doing it. And to me, I look at that and I'm like, oh, that must be really tough, that's really tragic. But when I speak to these people, they talk about their kids as their saving grace. Actually, they talk about their children being what university was to me, which is the thing that changes the course of their life and brings them forward into a new phase of happiness and meaning. Next slide, please. So I did some Googling, and it turns out that it's not immediately intuitive what makes life meaningful or worthwhile. So this is Andrew Solomon, who's a psychology professor at Columbia University, who does research, and he works with parents of exceptional children. So that's kids who have terminal illness or very severe disability, or rarer examples like the parents of kids who are serial killers. Or essentially, these are experiences that most parents would do absolutely anything to avoid happening to their child, right? And yet, Andrew Solomon found that the parents who have actually gone through these experiences don't tend to wish that they hadn't happened. So they don't wish that they'd had different children, for example, or they don't wish that their children had never been born. Now, this is astounding to me, right? Because these are the things that I feel so much for the parents who are going through these narratives. But then again, I was thinking that I wouldn't change the hardest things that have happened to me, not only because they brought me to where I am now, but also because they're very inseparable from who I am as a person. So to have different experiences would be to be somebody else. Next slide, please. So with baby P, I continue to find it really difficult and really unfair that her odds are already poor. But I have to remember that I don't know what directions her life's going to take her in, and I don't know how she'll feel about the directions in which she ends up going. And more significantly, I think, I really don't have the right to decide that she should be somebody different, that it would be better for her if somebody else with different parents or with a different birth history took her place. But there's another dimension here which I have kind of conveniently skimmed over, which is the role of basic material well-being. So the fact that people can find diverse meanings in the diverse experience of life, that's all fine. But if you don't have enough to eat, or if you don't have somewhere to live, or if you don't have clean water or whatever, then you're really not going to be happy no matter what else happens. Some things are necessary preconditions to be happy or to be well, even if they aren't in themselves sufficient for happiness. Next slide, please. So that brings me back full circle to where I was at the beginning, which is, what do we mean by optimizing health for baby P? Physical health, like food, water, somewhere safe to sleep. This is a necessary prerequisite for well-being. It's easy to forget about things like physical health if, like me, you're lucky enough to have always had it. But if you don't have it, it really dominates your whole life experience, as I realized dramatically when I got the flu last Christmas. So baby P, she might encounter all kinds of barriers to her mental and social well-being as she grows up into an adult. But it's only through the efforts of doctors or nurses and scientists that she's able to grow up into an adult at all, right? So even if she doesn't end up making the same great choices that have made me really happy, at least she will have her own choices to make. And that's thanks to things like the NHS and the protection of her physical health. So that's my happy ending, right? Many things might be uncertain for the children that I met on the ward or the children that I take care of in the future. But the thing that I can do as a medic or a doctor or a pediatrician is look after their physical health. And that is also pretty good. Next slide, that's me. Thank you.
Okay, that's great. Thank you so much to you all, to Amadine, Ella and Kelvin. Does anyone have any questions?
I think not a question, but like, I mean, just to add to the depressing aspect of your presentation, Kelvin, if you think about your patient in particular, it even goes like from a physical health point of view beyond even like the odds being stacked against them at birth, because if you think about like gestational health sort of thing, and if you know, if they were born with like withdrawal, you know, it's just already from like day zero, you've got such like poor long-term health outcomes compared to the baby who's being born in like the delivery room next to you. So yeah, it's just very sad. But you're right that even just remembering that when you're dealing with these patients, and just remembering that the family structures may not be what you expect, and that not everyone will have you know, two parents to look after them, or like a loving parent who will be able to provide for them, is like really important. So yeah, really grateful for your presentation overall. Thank you.
Great, thank you so much. Thank you to all of you. And whilst the judging panel are scoring up all the presentations, I just wanted to remind you all, if you haven't, if you've missed any of our Careers in Paediatrics online workshops, or you would like to watch this workshop at a later date, then please, by all means, go onto our YouTube playlist and you'll be able to see all our previous online workshops. And I also want to remind you all to sign up to our Aspiring Paediatrician membership as well, that we have at the, within the RCPCH website. And this is to receive information from the UKAPS team and the RCPCH about events going on, any webinars and any new updates. And by signing up to the RCPCH membership, you'll automatically be a member of the UKAPS membership, so that will be great. And so yes, please do sign up to the membership, and you will also find out loads of new information like today, which was the launch of the brand new RCPCH careers campaign. So please do have a look at the new promotional video, which I've sent on the live chat. And so when you do have a chance, please have a look at the new promotional video for the careers campaign.
We'll quickly announce the winners for everyone. So in third place, Amadine, well done. It was a really good talk and really interesting about a holistic approach. In second place was Kelvin, and then our winner is Ella. So really well done, and thank you all and everyone who applied for the Tony Jackson Prize as well, and to our 3 finalists for speaking today. It's been a great webinar and we hope everyone's enjoyed listening to it.